When most people think about diabetes, they think about numbers, blood sugar readings, lab results, medications, diets. What they rarely think about are consequences that don't show up on a screen. They don't think about nerves slowly losing their ability to sense pain. They don't think about blood vessels quietly narrowing. They don't think about wounds that never heal the way they should. And almost no one thinks about amputation. Yet across the world, diabetes is the leading cause of non-traumatic lower limb amputation. This does not happen suddenly. It does not happen dramatically. It happens quietly, over years. To understand how this happens, we have to look beyond glucose numbers and focus on biology, behavior, and time. The term non-traumatic amputation is important. It means the limb was not lost to an accident, war, or a sudden injury. Instead, tissue failed gradually because of disease. Globally, between 60 and 70% of lower limb amputations are associated with diabetes. That makes diabetes the most common cause of non-traumatic limb loss in the world. This fact surprises many people, including some who have lived with diabetes for decades, because the process is rarely explained in a way that connects the dots. Diabetes is not dangerous because it affects a single organ. It is dangerous because it affects multiple systems at the same time. First, it damages nerves. Second, it damages blood vessels. Third, it interferes with healing and immune response. Each of these problems alone can often be managed. But when they overlap, the risk changes completely. Amputation becomes possible only when several protective systems fail together. One of the earliest and most important changes in diabetes is nerve damage, known as peripheral neuropathy. This damage does not happen overnight. It develops slowly, often over many years, so slowly that people adapt without realizing what they have lost. Pain exists for a reason. It is the body's warning system. It tells us when something is wrong, when to stop, when to adjust, when to seek care. When sensation fades, injuries do not stop happening. They simply stop being noticed. A shoe that rubs in the same place every day, a blister that doesn't hurt, dry skin that cracks. Individually, these seem minor. Together, they can become dangerous. Many people later say the same thing. They didn't feel anything wrong. At the same time, nerve sensation is declining. Diabetes is also damaging blood vessels. Circulation to the lower limbs becomes less efficient. Oxygen delivery decreases. Nutrient delivery slows. Healing is an energy-intensive process. Without adequate blood flow, even small wounds struggle to close. The body attempts to repair itself, but it cannot complete the job. This is why small injuries linger instead of resolving. This is how many diabetes-related amputations begin. Not with a major injury, but with something minor that never healed. An open wound creates a pathway for infection. Diabetes makes infections harder to control. Immune responses are impaired, and antibiotics rely on blood flow to reach tissue effectively. As infection spreads, tissue begins to die. By the time pain appears, damage is often advanced. At this stage, the goal of care changes. Amputation is not a failure of medicine. It is often a life-saving decision. It is chosen when infection threatens to spread beyond control, when tissue cannot recover, and when delaying intervention would risk life. It is almost always the last option, not the first. Many of these outcomes are influenced by awareness. Neuropathy often has early signs. Foot problems often start small. Education and routine screening do not guarantee prevention, but they change timelines. And in chronic disease, timelines matter. Earlier recognition means earlier intervention. Earlier intervention means fewer irreversible decisions. Diabetes-related amputations are also influenced by access to care. Late diagnosis, limited resources, missed screenings, and gaps in follow-up all increase risk. These complications are not only biological, they are systemic. They reflect how care is delivered, how information is shared, and how early warning signs are addressed. The CDC emphasizes that foot ulcers are a common pathway to amputation in people with diabetes. Nerve damage combined with reduced blood flow makes wounds more likely to become infected and harder to heal. If an infection does not improve with treatment, amputation of a toe, foot, or part of the leg may be necessary to prevent the infection from spreading and to protect life. This is why routine foot care is emphasized so strongly in diabetes management. The CDC recommends checking feet every day, even when they feel fine, because early problems are easier to treat. They also stress the importance of regular foot exams by healthcare providers, including checks for sensation and blood flow. Most people with diabetes can reduce the risk of serious foot complications through consistent care and routine medical follow-up. When small changes are recognized early, the trajectory can shift, often preventing minor injuries from progressing into life-altering outcomes. Diabetes has been recognized for more than 3,000 years. Medicine extended life. But survival revealed complications that develop quietly, without pain, without warning. A disease we have known for millennia still costs limbs, not suddenly, but silently. If you value clear, evidence-based medical explanations, subscribe for more. Follow for medically grounded explanations of how diseases affect the body. Subscribe for public health education without hype or misinformation. This content is provided for educational and informational purposes only. It does not constitute medical advice, diagnosis, or treatment. Always consult a licensed healthcare professional regarding personal medical decisions or medical conditions.